that's that propagation that we're talking about. And this is what it looks like from an epidemiologic perspective. We typically we'll see this with any person-to-person spread in the early days of an outbreak. And so it starts with one person. It takes an incubation period. So the time between these waves is typically early on. That's going to be your incubation period. And then these peaks and waves increase and they amplify over time. Eventually you lose the distance between the waves and they all kind of start merging together because of the number of people involved. But this is what we call and refer to as propagated transmission. And this is really what we're seeing with the COVID-19 epidemic or pandemic now. And a good comparison is that we can really look to a very similar virus in SARS, which emerged in 2003. And what we see then was in late December or late November of 2002, they've seen a few cases, some small little waves early on, but then really between January and February, they have their first big wave over time. And then you start to see the waves disappear, right? So they're merging into a bigger wave. You can still see those smaller clusters inside, right? You can see those smaller waves. But this waveform where that second bigger wave is typically what we see in respiratory infections. And so this gives us a little idea of what we might be able to expect or anticipate as best we can with a virus that we otherwise don't know that much about. And so let's talk a little bit about this waveform. It's important to recognize time, the role of time in all of this. It may be that waves are happening on a weekly basis, right? But in the Spanish flu of 1918, it really wasn't a single year. It lasted about 18 months. There were several different waves that occurred over years. And so that's where this time idea with waves becomes really tricky when you're working with something that's novel. So here's where we're at today. And just to kind of, let's look and see where our waves are at. So this is the epi curve for China, and what each bar represents, each vertical bar, is the daily new cases of COVID-19 that were diagnosed in China. And so you can see there's a nice gentle rise kind of hitting that exponential slope around the 17th, 19th. And that red arrow down is when Wuhan implemented their quarantine. And they quarantined over 60 million people, and it was quite rigid, and it's actually still largely in place, although they've loosened it a little bit. But you can see after a very rigid quarantine, they started to see a flattening of their curve and started sloping down. And so what's interesting is since China's cases have come down, the international wave is starting to happen now. So these black bars are the daily new cases outside of China. And so we are starting to see amplification of these cases that are happening outside of the primary wave. And I think what's really important to recognize is when we're talking about 200,000 cases globally, we have to realize that every country is doing things a little different. If you're South Korea, you're testing every person. If you're Iran, you're probably only testing the people in the ICU. And so there's a huge discrepancy in what it means to have a positive case. So I actually, and a lot of people have started shifting towards death data because that is a little more reliable, and it actually echoes the data on the daily cases. It's a little bit behind, so about 7 days or so behind the daily case data. But you can see there's a wave there that happened until about February 24th out of China. And then now we start seeing the increased daily death counts happening that really mirrors what we're seeing on the international side for total cases. And so I think this gets to the question, and when we talk about epidemiologic modeling, it's where are we going, right? And no one can actually predict this, but if we were to put just a normal, non-significant, this is not statistically significant, but this is what we might expect out of a normal bell curve with where we're at right now in our curve and our data. I think the challenge is that we have no idea what this curve looks like. We can take some good guesses based on what we're doing in different areas. And so it may flatten a little bit, right? And this is this idea of flatten the curve. It may flatten and we might be able to blunt it. The reality is we need to probably zoom out a little bit when we're thinking about these cases and where we're at. This is likely something that will have a big balloon now but last for many months. And so when we start looking at the modeling, it appears as though, you know, there's going to be a wave that lasts a longer time. There's also likely to be multiple waves. Again, it's hard to anticipate. So where are we at in Minnesota? I've been kind of keeping track here of our daily new cases. So that gets back to the kind of those early that epi curve that we're watching for our propagation and our kind of upswing on the curve. And I want to be clear that this is really variable, because when we're looking at daily data, the case count is going to be really volatile based on if there's enough reagent that day, or if they get a wave of tests in that they need to backlog them to the next day, or if it's a Sunday. So I would not put too much money in the daily count, but it's that trend over the next few weeks that we're going to be watching. That being said, we are certainly having more cases now than we did a week ago. And these cases, and I think Beth can certainly talk a little more to this, but what's good in our Minnesota data really shows us that most of these cases are mild. There are severe cases, and we've certainly heard about the critically ill cases, but most of these cases, even those that are being tested, are going to be mild. And early on, when I kind of first, a couple weeks ago, did this talk, there was a lot of question, well, how is this different than influenza? And I think in the time since, this has become less of a question as new evidence is emerging, and as a society, we're starting to recognize that this is very different. But just realizing the age differences in death rate. And again, you have to take death rates into account, you know, be cautious in interpreting those, just because you're only getting your N based on who you're testing, right? But just recognizing that there is a really big difference here with the impact to COVID-19 and versus flu. And so my background is in public health, and so I think about this from a public health perspective, and I just wanted to share a little bit about what's happening at the state and national levels. We know the most effective way to prevent infections and save lives is by breaking the chain of transmission. And this is really a three-pronged approach. So we're talking about diagnostic capacity. We need to be able to identify the people who have the disease. We need contact tracing. And so our Minnesota Health Department is wonderful at this. And traditionally, you know, if there's a gonorrhea outbreak, they have everybody's contact very early on. The problem and the challenge here is that there are so many contacts and so many cases kind of building that just resources are becoming limited in that capacity. And of course, from a diagnostic capacity, we are aware of kind of the limitations on testing. But case isolation then is another really big component. And that's why we're starting to have resource limitations on the diagnostic capacity and the contact tracing, we really come down to, if you can't identify who the cases are, and you can't identify who maybe the contacts are that you can keep them at home, you have to keep everyone home. And so that's really where this isolation idea and the social distancing comes into play. And by now we have all seen this curve, this so-called flattening of the curve, where there is a threshold for our healthcare capacity, and we want to protect our ability to care for critically ill patients and who have COVID-19 and those who are critically ill for other reasons. And so that's why you're seeing this really big push for the case isolation. And we know that social distancing works. If we look back to 1918, in the early fall of that year, we were starting to see an upswing in cases. And Philadelphia and St. Louis both had implemented kind of some social distancing measures. But in late September, September 23rd, there was a parade held in Philadelphia with over 200,000 people, and it was to celebrate soldiers coming back from the war. And St. Louis didn't. they kept the social distancing, they made it more strict, and you can see the impact that this had on ultimately the curve. And so, you know, especially when we go back to that last, you know, the healthcare capacity, and obviously this is a century later, we can see that it works. And so that's why there's so much investment in it now. And so I think I just wanted to, I don't have any other slides. I think the big takeaway points here is there's obviously a lot of uncertainty, but we can be confident that this is going to get worse before it gets better. I think when we're talking about school closures for a week, it's probably unrealistic. And so as we're kind of thinking about timelines, just being really aware that we're probably going to be dealing with this for at least the next year. It will be something that has varying degrees of severity, or it will impact different cities differently, even within the state of Minnesota. And so it's our ability to be flexible and adapt that's going to be really important. I think the other thing is recognizing that during this time, our lives are going to look a little different. But this will end. If we do everything right, we're going to look back and think that, you know, we did way too much. This was not as bad as we thought. And that's really, from my perspective, kind of the aim here. So that's all I have. And I think we'll take questions at the end, but I'll hand it over.
So who is going to be up next?
Okay, hi. Can everyone see my slides right now?
Yes.
Yep, so we can see them looking good.
Okay, hi, this is Beth. All right. So I'm going to be talking about what we know about SARS-CoV-2 in pediatric patients so far. And obviously this is an evolving area of understanding. Then I'll go over an overview of our system response to the pandemic sweeping through the nation, including our state and community. This will include our strategies for prevention of spread in the hospital and strategies for keeping our patients and providers safe. So Heidi went over a lot of these numbers already. I'm just going to do a couple of these maps again. In the US, as of last night, we have over 5,000 cases, over 100 deaths. Mortality rate is around 2%. And as of now, all 50 states are affected. I think West Virginia was the last state to report their first case as of yesterday. Minnesota, our first case was confirmed 12 days ago on March 6th. And as of the most recent data, which is coming from MDH from yesterday, March 17th, we have 60 confirmed cases out of a total of over 2,000 people tested. Ages range 17 years old to 94 years old. There's only one pediatric patient so far that's tested positive, and that's that 17-year-old. The listing on the right shows kind of where we stand in the context of the other states. For numbers, we're number 20. As far as our local numbers, in our mHealth fair use system right now, there are 3 total hospitalized confirmed cases. 1 at UMMC in the adult ICU, and 2 at St. Joe's. Right now, we only have 1 PUI at UMMCH in the PICU. Heidi already kind of went over this, a display of the epi curve in Minnesota. Remember that this lower green line is deceptively low, and it's not because we have fewer cases, it's because that we are at a severe lack of testing supplies and testing reagents, and we stopped all curbside testing yesterday. All right, so for PED-specific data, I'm going to try and discuss what we know, and I apologize, I might have missed some things. There's a lot of data coming out kind of all the time and getting published. But I'll go over what I found, what's out there, and then incorporate some of the lessons and verbal reports that I've been a part of out of Seattle Children's, and then some information that was gathered from a phone call involving multiple pediatric hospitals throughout the country that Dr. Marmot was a part of, and graciously shared some pearls from the call. And just as an FYI for terminology, the term COVID-19 is used to talk about the clinical disease, and SARS-CoV-2 is the virus. UpToDate actually already has a very nice article on COVID-19 in pediatric patients. I think the good news is that, as we're all seeing, this seems to be a much milder disease in pediatrics. We probably haven't been testing enough peds patients to really understand how many there are, but they certainly are not as high acuity as the adult cases, and really, I haven't seen any deaths reported except for one teenager out of China. This is another summary, a good summary article from the Pediatric Infectious Disease Journal from March 12th. They again kind of stress that children are less commonly affected by SARS-CoV-2. The Chinese Centers for Disease Control and Prevention reports that of the over 72,000 cases reported as of February 19 years of age. This is in a summary article if anyone wants to read it. They go through a bunch of different case series. All of these case series talk about kids being mildly symptomatic and recovering. There was a case series of 9 infants. I thought that was maybe interesting to look at. 4 of them were reported to have fever. 1 was asymptomatic. So from these series, it does appear that children have milder clinical symptoms than adults. This also is reported with SARS-CoV and MERS-CoV. I think, this could mean that, kids might not be tested as frequently as adults. And so, it has been suggested, but not proven, that asymptomatic or mildly symptomatic kids might be transmitting the disease, and we don't know it. So there was a nice a new article that came out this week out of China as the largest review of pediatric cases to date that I could find. It's a retrospective analysis of the epidemiologic characteristics and transmission patterns of over 2,000 pediatric patients, all less than 18 years of age, with either suspected or confirmed COVID-19. I think after reading this, I think we need to interpret it with caution, though, because they weren't all confirmed cases. Some were just suspected, so we might have a mix of infections in here, of cases that weren't necessarily COVID-19 and maybe some other virus that looked like it. But their data was from cases reported to the Chinese Center for Disease Control from January 16th to February 8th. They had 731 lab confirmed cases and over 1,000 suspected cases. The median age of their patients was 7 years. It ranged from a day of age to 18 years of age. Interquartile range was 2 to 13. They didn't see any statistically significant difference between number of males and females. They stressed that over 90% of all of these patients were asymptomatic or mildly or moderately symptomatic cases. And their severity of disease was defined based on the clinical features, the labs, the chest x-rays. So in this case series, which of course does mix together confirmed and suspected, they found 4% were asymptomatic. This meant no clinical symptoms with a normal chest x-ray. 50% were mild. This meant acute URI symptoms, fever, fatigue, myalgia, cough, sore throat, runny nose, sneezing. Some of them didn't have a fever. Some of them had some digestive symptoms like nausea, vomiting, abdominal pain. The moderately severe ones had pneumonia on X-ray. They often had fever, cough. Some had wheeze, but no hypoxemia. And then they reported up to 6% that were severely or critically symptomatic. But they did note that there are more severe critical cases in the suspected group as opposed to the confirmed group. So it does remain to be determined whether, you know, the severe and critical cases in the suspected group were actually caused by COVID or maybe something else like RSV. They divided everything out by age, and I think the point was that, you know, all age groups had some positives in them. So kind of any age could potentially be infected. They had some discussion points about, you know, why are children having less severe disease than adults? I don't think anyone has the answer to that. They speculated on some things. I think one interesting theory had to do with the angiotensin converting enzyme 2, which is known as a cell receptor for SARS-CoV. And the 2019 coronavirus has some amino acid homology to SARS-CoV. So it could be that it's, you know, can use the same ACE2 as a receptor. And some evidence indicates that, you know, ACE2 is the cell receptor for the novel coronavirus. And, you know, it's speculated it can to the virus because the majority and function of their ACE2 is lower than adults, but this is all speculation. So again, the study's strengths are that it's the first nationwide study to focus on epidemiology of COVID in children. It does show that severity in children is much less than adults, but the limitation is that, you know, it kind of looks like maybe there's more severe and critical cases than true because they mix together suspected and confirmed. They also talked about the kind of the pattern of cases, the rise and fall of the number of cases rose pretty dramatically in January, and then by February started to level off. There's already a consensus statement out there from China, and it has some, you know, helpful guidance that they put together from their experts regarding the spread of the disease and management in children. They do talk about how respiratory droplets and contact are the main transmission routes. This one was a nice study looking at clinical and chest and CT features in PEDS patients with COVID-19 infection. And they were trying to differentiate, you know, the patterns in kids versus adults. So this was a case series of 20 pediatric patients that were in the hospital. They had COVID-19 confirmed infection. This was confirmed by NP swab, PCR, and it was a retrospective analysis. You know, they had 65% of these patients were, you know, diagnosed after having close contact diagnosed family members. 60% had fever. 65% had cough. These were the most common symptoms. As far as laboratory findings, this study found that 80% had a high procalcitonin, which is not something that was seen in the adult studies, so maybe we should pay attention to that. And then the other big finding out of this study was that 40% of their patients had co-infection with another virus, and you can see the co-infection pathogens up here. Of course, it was a small study, so like 8 out of 20. And so the point was that, you know, if you find, say, RSV or influenza in a patient, does not necessarily rule out COVID. You could have both. And then they describe the different consolidation patterns that you can see. It can be unilateral, it can be bilateral. They found a special finding that hasn't really been described too much in adults is the halo sign that was seen in 10 patients. There's a lot of ground glass opacities that's been described in adults also. So their conclusion was procalcitonin and consolidation with a halo sign might be specific to pediatric patients. That's not in adults. This was another article just to say that you can have influenza A and COVID at the same time. I've been looking and looking and trying to find evidence of COVID disease or severe disease in patients that are immunocompromised or have chronic conditions, and I haven't been successful, and I don't know if anyone else has been. If so, let me know. There's this one report that was posted on Twitter. It's a Chinese article, and I tried to get it translated on just like Google, but it was translated on Twitter. And from what I understand, this is a case report of an 8-year-old's T-cell ALL that had the novel coronavirus. And that's the only one I could find. Regarding pregnant women and vertical transmission, there's not much data yet. This is a small case series of 9 pregnant women who were infected with SARS-CoV-2, and none of their newborn babies were affected by the virus. And I haven't found any true evidence of vertical transmission to date. They concluded from this study that the clinical characteristics of COVID-19 in pregnant women are very similar to those reported for non-pregnant adult patients, and that they not increase for severe disease. And so far there doesn't seem to be evidence for intrauterine infection, although this study was all in patients that were infected during their 3rd trimester. So I don't know if there's going to be different data for patients infected earlier than that. UpToDate also has some information about pregnancy. They put together some additional studies. But again, it doesn't seem like anyone's found a vertical transmitted case. There's been a couple of cases described in neonates, but one of them was diagnosed at 17 days of age, and that was attributed to close contact with an infected adult. And then the other case, the transmission was unclear as to how it happened. And in this case report, all the APGAR scores were 8 and 9, so the babies did pretty well. So it was helpful for me to listen to this webinar and be part of this Q&A out of Seattle Children's, as they're kind of in the depths of their outbreak. I think some of the key points from their hospital was that it does seem to be a low acuity situation for pediatrics, but they talked a lot about how it's really not playing out that way on the adult side. Some adult hospitals are at their maximum capacity. They're requiring movement of adult patients into pediatric units of community hospitals. So they stressed, it's important that maybe this is a critical situation for the pediatric population yet. The larger issue is maybe how can we support our adult hospitals and care centers when they're surging. At Seattle Children's, they have tested about 600 patients in their hospital and only 6 positive so far. The other point they stressed, which we got to remember too, is careful use of PPE and reusing as soon as possible. There's some other points that were nicely presented on a webinar done by the CDC Clinician Outreach and Communication Activity. Again, they kind of point out there's not, this disease seems to be mild in infants, children, pregnant women compared to adults. There's not data on medically complex children. And they point out this 40% co-infection rate again, influenza, mycoplasma, and RSV. It could be higher. I don't think the study looked for like an entire RVP panel. This webinar does describe a stillbirth in a COVID positive mother. I wasn't able to find that case, but it must be out there. They stress no deaths in children under 10. Again, there can be lab abnormalities that seem to be consistent with this disease, where you can have mildly elevated liver enzymes, and then often it's leukopenia. They describe leukocytosis, but most of the reading I've done looks like leukopenia. And your imaging, you can have unilateral, bilateral, or no findings. There's no treatment. There's clinical trials for remdesivir. It's only for adults. This, the UMMC is one of the clinical sites that's enrolling. I don't know that they're enrolling yet, but they are a site. And then there's some compassionate use exceptions. So I don't know, maybe if there's an older teenager or something, then could potentially contact the company about a compassionate use. One other point that came up was that the CDC had recommended avoidance of high-dose steroids unless it was otherwise medically indicated because it can prolong viral replication. But this was something that was extrapolated from MERS-CoV and not necessarily observed in this current outbreak. So from Dr. Marmot, he had a lot of good pearls. I just put a couple on here. Basically, you know, from this meeting, it sounded like there was a lot of good ideas and, you know, report outs of what people were all doing in their hospitals to, you know, conserve PPE for testing and for cohorting strategies. But I just kind of put up here that, again, despite all the testing that everybody's doing, the positives in kids, low number of critically ill kids. So, you know, we might need to consider conserving tests by testing fewer kids. But Heidi shared with me this wonderful link this morning at 4 a.m. that I think is a nice summary of all the PEDS literature that I kind of wish I would have had earlier. Okay, so moving into our mHealth Fairview response to this outbreak. As you know, we have a system incident command set up, and this is this is for rapid coordination of response and planning for our system. So we've got, so there's the system incident command, and then underneath that there's an ambulatory incident command, a UMMC incident command, and one for home health, and I think there are some others too, but they all report up to system. So I just want to stress again the importance of checking the daily emails from Command Center that are entitled COVID-19 system update for all the instructions of what we're supposed to be doing. And they change every day. A lot of the recommendations change, and it has to do with kind of where we're at with our, you know, epidemiology, but also where we're at with testing supplies and where we're at with PPE, because it does kind of change day to day and waffles between being in a contingency mode and a crisis mode, and it may differ depending on which PPE we're talking about, whether it's PAPRs or N95s or surgical masks. So just pay attention to that. And then there's a really good resource on our intranet, the infection prevention page, the coronavirus readiness page, and it's got all the good links for how to do PPE and testing resources and all of that. And I included some links here. This is the link to the intranet page I'm talking about, and then some other good links there for your reference. So what have the strategies been? Basically, you know, we want to prevent the spread of the virus in the hospitals and clinics. So I think you all know the things that we've been doing so far, you know, visitor screenings, no visitors allowed. We've gone to really strict visitor restrictions. Pretty much no visitors are allowed at all, you know, except for our PEDS patients, they can have a parent. An OB patient can have a visitor, and then everyone else is basically just compassionate exceptions if they're dying. Our entrances are controlled, valet services are canceled. The registration desk has an epic alert for who to give a mask to and put into isolation. You know, and then obviously we need to do strong adherence to our IP practices and protocols for COVID-19 in the hospital. We've gone to working from home, and anyone that can do that to keep people distanced. There's no facility dogs or therapy dogs. no medical students, and then, e-visits and telemedicine when able, canceling of elective surgeries, no large group meetings, etc. So then I kind of wanted to move into some specifics about our infection prevention practices surrounding COVID-19, and I'm going to have Hoy go ahead and give us some information about what we're doing there and kind of what to keep in mind.
Sounds good, team. Let me just get my information up. Does everybody see my screen?
Yep, we can see it.
Yep, looks good.
Perfect. So thank you, Beth. Thank you, Heidi, for bringing me in the loop. Appreciate everybody's efforts and just willingness to collaborate and align our practices. As Beth mentioned, I'm the pediatric infection preventionist. I'm a nurse by trade coming from the PEDS BMT unit. Today, I just want to go over, again, just some of the major changes that we have in regards to PPE use and prioritizing negative airflow rooms. Beth mentioned this earlier, but I just want to reinforce the importance of this page on our intranet. This is our source of truth, and we advise and direct unit staff, frontline staff, providers, nurses, managers, all alike to make sure that they reference this page. This is in collaboration with the CDC and MDH, and we're posting the most pertinent information on this site that impacts your practice. So all the materials have been cleared by system command and can be disseminated. But it is important to check this site regularly just because it is updated constantly. If there is anything that you need to help your practice, please just let infection prevention know and we'll get information up for you. I think the biggest change that we've seen this week that's impacted our frontline staff, whether your aides, RNs, or providers, is just the change that we went with our PPE guidance. So earlier on, as we approach these situations with the highest level of protection, as our understanding evolves, we have changed our PPE guidance in regards to settings. We went from airborne to droplet for all ambulatory, including drive-through testing when that opens back up. Our emergency room, acute care, Ebenezer, hospice, and home care. All those areas do no longer require N95 mask. Droplet plus contact plus eye protection is needed. So essentially surgical masks, eye protection, that could be a face shield, that could be a mask with the shield, that could be goggles, gown and gloves. Again, N95s are no longer required. Where they are required, however,
Are there slides with pictures of this, or what we're seeing just says M Health Fairview? I just want to make sure you're to show.
Oh yeah, there is a slide. I'm sorry. You're not seeing this at all, are you?
No, we're just.
How about
There
this?
we go.
All right, there it is. Okay, sorry about that. Thanks for the heads up. Everybody still sees this?
Yes, but we're not seeing it.
We're seeing like the just PowerPoint screen. If you put it like you're presenting, we'll see it like how it would look on a slideshow.
Put it into slideshow.
Okay, give me one more.
That's the button.
Yeah, it's, for some reason I won't click over here, team.
Well, we can see it just
You can
fine.
see it. We'll just go with this if that's okay with you. All right, so again, the biggest change here is it's a change from PPE for settings. So for EMS, for ICUs, or when performing aerosol generating procedures, that's where we still need to keep airborne precautions in effect, in addition to contact precautions and eye protection. So PAPR, capper, N95, eye protection, gown, and gloves. So those are the two biggest changes that we've implemented this past week that have caused the most churn on our floors. And from an IP perspective, we're out there, we're providing education. Two driving factors in regards to this change is, yes, one of it is supply. That is driving our actions, but the other one is just the evolving knowledge in regards to the common mode of transmission via droplet and contact. And then two signs that you'll have to take note of. This sign here is the gray sign that is created for the COVID patients. This gray sign here, are you seeing this gray sign, team?
Yep, we got it.
Okay, this gray sign here will be used for the non-ICU settings. So in acute care, it lists contact, droplet, eye protection. And what's important here is we do specify when possible during aerosolizing procedures, place the patient into a negative airflow room or a room with a portable HEPA filter and keep the door closed. We understand that this isn't always feasible or possible in all settings, but we do ask that we prioritize that when possible. This sign here is different from our actual ICU sign, which is in black. And if you see here, airborne contact and eye protection is the biggest difference. And you're going to see these signs in the ICUs, including for the PEDS building, Unit 3, CVICU, and the PICU, as well as the NICU. Again, the biggest difference here is airborne. And if you do see this sign on an inpatient floor, it's because they are generating aerosols through intubation, through nebulizer treatments, through CPAPs, and so forth. And to segue into aerosol generating procedures, there is a little bit of an update in regards to what we consider AGPs at this point in time. So in addition to what we typically consider AGPs, as of now, we're looping in and including nebulizer treatments, CPAP, BiPAP, any positive airway pressure ventilation. Historically on the floors, we may not have treated those types of treatments as aerosolizing procedures. With this COVID situation, those treatments will be considered aerosolizing. So if you have a patient that is under only droplet and contact and eye protection, if you plan on doing an aerosolizing procedure, then you will have to take those precautions. I will say that for PPE specimen collection, NG swabs often generate a strong cough reflex. Droplet plus contact and eye protection is recommended for that. Here is the airborne isolation room prioritization. So we're asking frontline staff to prioritize negative pressure rooms for patients with airborne infectious diseases like pulmonary TB, disseminated shingles, measles, so there's no change there. We're also prioritizing the negative rooms for PUIs or positive COVID-19 patients in the ICU, or PUI or positive COVID-19 patients requiring AGPs. Now, for situation 2 or 3, COVID patients in the ICU or COVID patients requiring AGPs, if transferring to a negative room is not available or possible, then healthcare workers must wear N95, PAPR, CAPR, eye protection, gown and gloves in that standard private room with a private restroom. So we want to make sure that we're isolating that room if we don't have a negative air pressure room. For situation 3, for aerosol generating procedures, again, healthcare workers must wear N95, PAPR, CAPR, and a PPE. The room door must be closed during that procedure. And this is an important part. For 69 minutes post that procedure, if you remain in that room, all your PPE should stay on. 69 minutes is the proper air particle clearance time based on our air exchanges to clear out particles at 99.9%. So if you remain in that room while you've done an AGP, and you cannot leave, then your PPE should stay on. And if you do leave, that room is not cleared until 69 minutes later. So it's very important for frontline staff to notate when a aerosolizing procedure begins, and 69 minutes post that time for staff members to safely enter that room without N95s or if that door is open. On this next slide, I just wanted to share this link that we can share offline as well. It's a NETEC video for PPE for COVID-19. As far as videos go, it's very thorough, and I really strongly encourage you to watch this. In light of our social distancing, we aren't able to provide in-person practice sessions for doffing and donning, which is really what's required to really be able to don and doff effectively on the floor, especially if you're in a high-stress situation. So I strongly encourage you to watch this video. Starting at 6 minutes, it's about 12 minutes total. It'll walk you through the entire process, and it's very thorough. I would encourage you to watch that, and then I would encourage you to bring the guidelines, the checklist that we've created on our site to the floors. So then you have a manual, a checklist in front of you that you or your buddy can help you in regards to your donning process. So for today, I just want to walk you through the tools that we have and then answer any questions that you have in regards to the process. So I mentioned before, bringing this checklist to your unit prior to seeing your patients is going to be very helpful in helping you don and doff your PPE. We do recommend having a buddy, if possible, in regards to donning and doffing. And these two checklists here, one is for your mask or N95 with disposable gown. One here is with your PAPR and disposable gown. Depending on where you are practicing, some areas, some facilities use reusable gowns. There's a slight difference in regards to how that process is done with doffing, but that checklist is also on the intranet page. So everything that you see here is posted on that COVID-19 resource page. I'll go over the donning and doffing instructions for N95, and then after that, there are some for PAPRs as well, but I just want to at least walk through this with you just to get a better understanding and to answer any questions that you have. It's really important, first and foremost, is to perform hand hygiene prior to donning and doffing PPE, or donning PPE. We struggle with that as an institution and all multidisciplinary teams. We tend to forget hand hygiene prior to putting on those gloves. So really, when it comes down to donning PPE with your respiratory protection, you got to secure your hair from your face first and foremost. With these situations and HSIDs, you have to visually inspect your PPE prior to donning, making sure that it's not ripped or torn. Perform hand hygiene, and then you don your gown first. You want to ensure the gown is large enough so that you can have some unrestricted movement. You want to be able to move around, move your arms, so it's good to kind of rotate yourself a little bit to make sure that you have that flexibility, that movement. Secure all ties and fasteners. You know, we want to make sure those gowns are tied. The gowns are only as good as the user and how they're efficient. So when you tie your gown, if you can't tie it in your back, if you aren't able to tie in your back, you can wrap around and tie to your side or your front with the goal that those ties should not be hanging low or should not be hanging into the patient environment. After that, you would don your gloves. And our reusable gowns have thumb hooks on them. Make sure you hook your thumb into that thumb hook prior to putting your gown, your glove over that. The glove should secure over the opening of your opening of your arm sleeve. And then you want to verify the integrity of the PPE, the ensemble. Oh, I'm sorry, I skipped over the respiratory. This is an important part. Make sure that you're fit tested, and we'll talk about this more in a few more slides here, but make sure you're fit tested with N95. Make sure you know your size. If you have facial hair, it's very important to make sure you've been fit tested correctly. If you haven't been fit tested in a few years and you've had any severe weight loss or scarring of your face or just facial changes, it's good to get fit tested again. And then you don your mask with the bottom band first and then the top band over that. And then you put your gloves on, and then you verify the PPE integrity, and then you make sure that you have your full movement with your PPE. Doffing, similar type. The goal with doffing is to make sure that you take off all your PPE without contaminating yourself or the other environment around you. It's really important to note too that all doffing should take place inside an airborne room if it's an airborne patient, with the exception of your N95 mask. That stays on when you exit. So when you're getting ready to doff your PPE, disinfect your gloves, remove your gown. So again, how this picture is showing, you want to make sure that you're pulling the gown away and bunching it at the same time, so anything that's on that gown that doesn't potentially drop or spread somewhere else. As you roll down, you keep your gloves in your hand, you break it apart, and you throw it away. At that point in time, you perform hand hygiene again. And then you remove your eye protection, and with your mask and with your eye protection, you want to lean forward a little bit so that anything that's on there doesn't drop down on your body. Once you lean forward, you pull that off. You don't want to touch your face. You don't want to touch anything if possible. Perform hand hygiene. Then you exit the airflow room, making sure the door shuts behind you completely. And at that point in time, you take off your N95. Similar approach, leaning forward, pulling the bands off. N95s can be reused, however, for patients under droplet in contact, like COVID-19 patients, you cannot reuse N95s because they're under contact. If there are patients that are just under droplet for flu, you can reuse those N95s up to 5 times, and we can talk more about that here in the next few slides. Before I move on, are there any initial questions in regards to just donning and doffing? Perfect.
I'm
So
just
here's-
looking at our time here, Hoy. We're just have a few minutes left, and I know we have a large number of questions. I think maybe the conservation and reuse is the
Sounds good.
most pertinent.
So here's the PPE conservation slide here. We are currently in our contingency plan for N95 PPE use. So please reuse N95s as outlined. I mentioned earlier, you can use them up to 5 times for just a droplet patient. If you're under contact precautions, you cannot use them again. You want to minimize the amount of staff that goes into patient rooms. That means during rounds, 1 provider. That means if you can go there without another a provider to minimize mass, please do so. And that goes for pretty much all patients under precautions right now. The reuse protocols for N95 masks and capper, pappers, and surgical masks are posted on that intranet site that I mentioned earlier, so please review those. And then for fit testing is occurring this week. So for those of you that haven't been able to get fit tested, please look at this, this schedule here. There's fit testing today and tomorrow and Friday on both Banks and Southdale. So if you haven't been fit tested yet, please go ahead and get yourself fit tested. And then lastly, just if you have any questions, feel free to give us a call. Thank you.
Great, thank you so much. And I would just really encourage people to go to the Fairview intranet, as all of our speakers have mentioned, because things do evolve really rapidly. I'll pose a few of the questions that we've had so far. I want to start with the aerosolizing procedures. The specific ones I wanted to ask about, so these are probably for you, Hoy, and Dr. Swanson, are high flow nasal cannula and deep suctioning. Are those considered aerosol generating procedures? And then it sounds like you're recommending that it's a 69 or 70 minutes from a nebulizer treatment, but just if you could clarify, is it any aerosol generating procedure you would wear an N95 for that 70 minutes?
Yes, so any aerosolizing procedure for a COVID-19 patient, you would wear the N95 for that duration of the 69 minutes to allow for adequate particle clearance time if you stay in that room. So it is important to notate that on, and that 69 minutes is an overarching time frame because not everybody knows what their air exchanges are in specific rooms, whether that be clinics. The 69 minutes overarching will ensure 99.9% of particle clearance for all areas.
And high flow nasal cannula and deep nasal suctioning, are those considered aerosolizing procedures?
Deep suctioning is, and there should be something that comes out with a more extensive list, but I'll let Beth respond to that.
Yeah, so this is kind of a question that we're trying to resolve at Incident Command Center. Even yet, I think it's a top priority for today because there are some questions about high flow nasal cannula. There is an actual work group at Incident Command coming up with definitions of what's aerosol producing. So that's coming out, and I don't want to say something wrong right now.
Yes, that's fine. I was just on a conference call with the emergency department providers from Children's Minnesota yesterday, and they have also been struggling to define what constitutes an aerosol generating procedure and those time limits after the room. So I know that it can be tricky.
If we do wind up, including neb treatments and other things that we haven't historically treated as aerosolizing procedures, the one asked to providers and pharmacies is just to review what that impact would do to a patient in regards to a patient having Q4 neb treatments. Something to think about if we were to include that and how that impacts workflow in regards to patients that have a lot of treatments regarding nebs or those. So something to think about as you look at a patient's care.
Totally agree. I think I'm going to let's do 2 more questions, but what I'll do is connect with our outstanding speakers today and try to put together a little FAQ of all of the questions that have come through the chat, just because there were some great ones. I want to ask about a newborn baby, either in the regular newborn or NICU, and the mom is positive. Is there any guidance yet on that case?
Yes, there's actually a full protocol that there's a link on the internet page for how to deal with COVID positive pregnant moms. So just go to the link from the coronavirus infection prevention page for that.
Great. Yeah, I think the big thing I would say with the PPE questions is to take advantage of the expertise that we have. We have a COVID response team on our inpatient units 24 hours a day. And I think that for everyone just to be patient, that the PPE recommendations are evolving because we're managing a situation we've never had to manage before, which is treating our resources as limited. We're used to just using as many masks as we want. And so the idea that we're trying to conserve these resources is really different. Lots of great questions about immunocompromised patients and what we should do with them. So we'll try to send out some additional information about that, put out some information for healthcare workers who may have a immunocompromised family member at home and what that current guidelines are. I want to be mindful of everyone's time because we all have lots of other meetings going on. Just a brief on attendance. We're going to send out an email to the Grand Rounds listserv with just a brief form where you'll say, yes, I watched the Grand Rounds. We will also put that link on the Grand Rounds website. So if you attended today and you would like to claim CME credit for attending, please note in that way. I did record it. We'll try to figure out about circulating the recording as well and hope to get some further information addressing some of the chat questions out by later today or tomorrow.
Emily,
yeah, go ahead.
Emily, it's Joe. Quickly, before we go, I want to mention that Dr. Tolar is doing a faculty staff forum at 9 o'clock. That's also a Zoom meeting, and that invitation should be out to everybody.
Yeah, I would encourage everyone who is able to join that. And yeah, be patient, be kind, be safe, wash your hands, and just keep your eyes out for all the new information that's coming our ways frequently. Have a great day, everyone.
Thank you, everybody.
Thank you.